like? Shake like 15 minutes at least for my stuff. You can be honest. No. Alright. 15 minutes? Oh, thank you. I appreciate the 15. I appreciate that. Alright guys, come on. So, yeah, as long as you're listening here and your flavor's like, I think you guys will be alright. Any questions about yesterday? Were you able to, let me turn this on. Those two ones we kind of did at the end, these two, how'd you feel? Did that work out as far as naming those, finding the right spondylolisthesis? Anybody have any issues with that? Questions about this one or this one? No? Okay. Just remember, right? When we're naming the direction of this, it's the opposite of everything else we learned. You're naming it based off of the superior vertebrae and the direction that that vertebrae is going compared to what's below it. Whereas all of your displacements, which are bone fragments, and dislocations, which are joint involvements, are named for the direction that the distal segment is moving compared to what's proximal to it. Right? So don't get those ones mixed up. Okay. Thoracic spine. We'll jump right in. This is probably the shortest section of any of the body parts because there are very few images we do on this. We rarely image the thoracic spine. And yeah, there's your anatomy. Just a review of the anatomy. There's your musculature in your thoracic spine. Most commonly your cause of your thoracic back pain is not usually bony. It's usually all these guys. Now, here's your normal radiograph. I have numbered these for you. I have taught you, and we'll recover it in the lumbar area, how to count your cervical spines, how to count your vertebrae in your lumbar spine. In a way, we'll go over that part again when we get to lumbar. If I give you a thoracic spine x-ray, I will label them for you. This is too difficult to know for sure, right? Because look at your lateral here. Where do the ribs start? I don't know, right? It is too hard to tell, right? Maybe if I gave you an AP, you could, look at where the ribs come in, like here, and then if I gave you L1, you could see where the ribs come in. If I did that, but lateral, it's not possible, right? And especially at your level of what I need you guys to know. So if I give you a thoracic spine x-ray, especially if it's a lateral, I will label it for you if I want you to recognize the vertebrae. So what does that mean? I'm probably not going to give you one that you have to recognize the vertebrae because that's a really silly question. You'd be like, which vertebrae is it? And I label it T8, right? Can't do that. So, but you could. Yeah, that would go. I'd be in PD's office real quick. You'd be like, what are you guys doing? Like, what is this? So if you get an image of a thoracic spine, it's going to be pretty much just asking for the abnormality, right? Do you see a compression fracture? Do you see a burst fracture, which we'll talk about later? Those kinds of things. It's not going to be a numbering thing. So don't commit brain power to trying to learn how to count the thoracic vertebrae. But the cervical and the lumbar vertebrae is fair game. Okay? All right. So here's your normal radiograph. Now, a couple of things I want you to take a look here on this and kind of understand the why things are looking the way they're looking. Primarily, look at my lateral. Now, would you say that some of those vertebral bodies look darker or more radiolucent than some of the other ones? Is that because there's something wrong with the vertebral bodies? No. It's because of the location of the body, right? These are sitting right in the thorax and where the lungs are at. So when they take that breath in, there is way more air than there is in the vertebrae that are down in the abdominal section. So by just what we've talked about and the physics behind radiation and the x-rays, right, we're going to have more radiolucent vertebrae in the ones that are in the thorax region of the lungs because I have higher energy photons, higher energy x-rays going in and penetrating because I have nothing to slow it down because it goes right through air. So they naturally are going to look darker. However, when I get down here into the abdomen area, I got liver and spleen and all that soft tissue that slows down that radiation, so they're going to look lighter or more radiopaque. That is normal. That is normal, okay? It's one of the reasons why we don't use the thoracic spine to try to find that osteoporosis stuff, because I can't, is that density issues or is that because of the lungs? I don't know. That's why we use the lumbar spine, because we know the lumbar spine has all that soft tissue. We know what it's supposed to look like. Okay? So just know that that is normal. Now here you're still going to draw your lines. You can still do your anterior vertebral line, your posterior vertebral line, and then your spinous process line, your spinal laminar line, just kind of like right in front of the ribs there. So you can still draw those lines in each area. So that way you're looking for any type of movement, shifting, spondylolisthesis. Rare in the thoracic spine, but it can still happen, right? Most of the injuries we're going to see in the thoracic spine are going to be like your burst or your compression type fractures. Here's what a CT looks like on the thoracic spine. Not this one, that's the x-ray. Right? But here's your different CTs. Now, are these with contrast, without contrast? Can we tell? Right. With, and we'll talk about why here in a second. Look at my kidneys. Look at the highlights on the kidneys, right? They're bright white-ish, you know, based off of this window. Also on my second one, what's this coming down right here? This big whitish tube coming down. That's my aorta, filled with contrast. If it wasn't filled with contrast, it would look similar to all the other soft tissue because it's filled with fluid, and fluid and soft tissue looks the same. Plus I got the heart here. That should be all gray, darker gray, unless it has contrast. It's got contrast in it. So these are with contrast, right? And so this is my main primary aorta. This is when it starts to branch off into some of the renal arteries, the splenic arteries. All of them, you know, don't worry about that. I'm not going to hit you on the anatomy of which artery is which, but definitely know contrast which is not contrast. And then we can see why we'll use CT a lot of times on the thoracic spine. Look at the amount of detail I'm getting on my thoracic spine on these couple of images over here compared to my x-ray, right? The x-ray is not great for the thoracic spine. There is so much anatomy, both superiorly and inferiorly in that it hides a lot of stuff. So if you have a legitimate concern, x-ray is still going to be your study you're going to do initially to evaluate stuff. But if you have your legitimate concern that there might be something wrong with the thoracic vertebrae, probably not a bad idea to do CT afterwards. If you see something and the radiologist like, kind of hedging, get that CT, you see a lot more details. MRI. Again, how do we tell the big difference between CT and MRI? Soft tissue stuff, right? Look at my CT here on the spine in particular. I know there's a spinal canal here, but I don't know where the spinal canal starts, where CSF starts. I can see the spaces for the disc, but I can't make out the discs, right? Then I go to my MRI, I can see the detail of the intervertebral discs. I can see the spinal cord. I can see the CSF. Now you notice this one's a little bit different compared to the last one where the CSF was white. And we talk about that T1, T2 that I don't really need you to know for the exam, but help you understand that just because I don't have the bright white on the fluid doesn't mean it's not an MRI, just one of those other weighted views, right? But we can still see the darker color, the darker gray, and then the medium gray to show the CSF versus the spinal cord. And then all of a sudden it kind of cruds out right here. If you look closely at your screen, you start to see like these little striations and lines, kind of really thin lines at the bottom. What's that? It's your caudate area, right? That's where the spinal cord starts to go into those fibers, basically. You can see it beautifully on MRI. Coincidentally, this is why we do lumbar punctures in this area, right? Because those things will just move out of the way when we stick the needle in to be able to get access to the CSF. This is a beautiful picture of explaining why do we actually do the lumbar puncture in that area. It's because of that caudate equina, and they'll just move away like pieces of spaghetti. All right, let's compare some images. Which one do we think is normal? Right, the straight one. Anybody know what the one on the right is? Scoliosis. Scoliosis. You will see this a lot. You will learn in ortho more specifically when you have to do something about this. Most of the time, it's watchful waiting. There are certain degree marks that I will spare you right now on when like they need to be referred for surgery and things along those lines. But a simple curvature of the thoracic spine, mostly thoracic spine, it can be other spines too, but usually you see in the thoracic, is going to be your scoliosis, right? And so you're still going to go through your process, right? You want to make sure there's no fractures. You're going to follow your cortex of each individual vertebrae, take a look at it. You'll likely have a lateral if you do this image for real in that aspect, right? And let me pause there. Exam-wise, shift gears. I've had a couple of questions about, hey, what images are we getting on the exam? Is it going to be just this? Is it going to be a frontal and a lateral view? Like, what can we expect? And much like in medicine, the answer is it depends. Sometimes you will get more than one image if it's needed. Sometimes you will get just the one image if that's all that's needed, right? So know that I will give you enough imaging to be able to get to the answer or get to the diagnosis or answer the question, whatever it is. In some cases, you only need a frontal view, like this right here, right? You don't need that lateral view to come up with scoliosis on this. So if you don't need it, I won't give it to save the bandwidth on the exam. And this is one other reminder for next Friday, right? Please, if you haven't tested out using a website instead of the app, please do, at least this Friday, try to log in, make sure it works for like the site test or something along those lines. Make sure that works, because the app will crash. The app will not work for my test. There's too many pictures. We tried it before. It's not a good idea. You don't have to take a test after everybody else does because your system wouldn't pull it up. So, all right. CT or MRI? CT, good. Sagittal, coronal, axial? Sagittal, okay. All right. Big yellow arrow sign. Bad. What is that? What do you think it is? Compression fracture. Good. Right? Why? I have my vertebrae that are supposed to be like this, and I have one that's compressed. It's shorter than the other ones. Okay. So we got the compression fracture, and again, you may not get this normal one on this side on the exam, but if you look at all the other ones, which one of these is not like the other? Right? Right there. So you're like, okay, compression fracture. Which vertebrae? I'm not going to ask you that because it's thoracic. Good answer. There we go. I'm not going to do that to you, right? You don't need to worry about that in the thoracic spine. I just wanted to hit that home, so don't stress about it. All right. Now here's the ultimate question. Let's get into that second order thinking. What do we think the most likely underlying cause of this compression fracture is? Osteoporosis. I haven't even given you a patient age or demographic yet, and you guys are already tracking osteoporosis. Good. That's exactly what you should be thinking. These are rare in non-osteoporotic patients. It can still happen, but you see compression fracture, that's what you should be thinking. So, perfect. So there's an example, right? I can give you this. I can ask you what's the abnormality, and it should you know compression fracture. Or I can go second order, not even tell you it's a compression fracture, and say what's the most likely cause of the abnormality, right? That'll be that second order question. You have to know the abnormality in order to be able to guess what the cause is, right? So, good. So that's your compression. Here's your burst fractures. Look at the difference. Okay? Not, well, these two. Very similar pictures. Different slices, right? And that's why, so this is the same burst fracture. They're just different slices at different levels of the spine, okay? Look at how many pieces your burst fracture is. The best way for me to describe a burst fracture versus a compression fracture. The compression fracture looks like it's just been squished, right? It's like you make that big sandwich and you squish it down. A burst fracture looks like it's been shattered. Somebody walked up with a hammer and kind of hit that vertebrae and broke it into a bunch of pieces, okay? If some of these pieces go into the posterior spinal canal here, you definitely have a high risk of having some neurological injuries because these are going to be floating around. They're sharp, floating around, kind of hitting on the spinal cord, right? That's not good. Can you have an osteoporotic patient have a burst fracture? Yes, you can. However, the history is what's going to lead you to be more suspicious of something. How do we think we get these? Trauma. This does not just happen, even if you're osteoporotic. Burst fractures don't just magically happen without some sort of trauma. What do we think the most common cause, the most common traumatic cause of these would be? I heard a couple of different things. The answer is motor vehicle accident, for those who said that. Falls, this would be really hard to do just from a regular fall, right? Really hard to do from just a regular fall. Maybe, I guess, if the little old lady is jumping 4 stories out of a window because the building's on fire and lands on her feet, that's possible. You're gonna have more lumbar injuries with that, but MVAs is the most common area that you're gonna get these burst fractures in that situation. High energy, axial load, you're gonna have neurological deficits, okay? And again, for the most part, one piece, maybe 2, right? We saw that one that had kind of like the little piece that was kind of floating off of it. So maybe 2 with the compression fracture. But again, the difference is going to be trauma versus no trauma. That's going to be one of your telltale signs. But then other than that, multiple pieces, right? If the vertebrae looks shattered, it looks like it burst into a bunch of pieces. That's going to be the difference between the 2. Burst fractures are most commonly in the thoracic vertebrae that don't happen very often in the other vertebrae. Again, still possible. This is medicine. Second I say it won't happen, I'll go see a patient who's had a burst fracture in the lumbar spine or something. So, but most commonly in there. Okay. What's going on here? An X-ray. That's a good start. No, don't laugh. I'm serious. That's a good start. Know what you're looking at first before you try to evaluate it. All right. So we got an X-ray. We know the anatomy section. Well, so it's a lateral X-ray. Right? We don't use sagittal for X-rays. It's not slices, but that would be a side view, so a lateral. But do we know what portion of the body it is? Thoracic spine. Good. Good. What's the abnormality? Compression. How many? Like 3 or 4 of them, right? There's a bunch of them here. So we got compression here, compression here, compression here, probably compression here. Right, 1, 2, 3, probably 4. Right? I wish I could see this vertebrae up here to figure out if that's their normal size or not, so I'm not sure. Right? I wish I could see that one. Why can't I see it? So the air a little bit, but this patient is so osteoporotic that that vertebrae is so radiolucent because there's almost no density to it. That's why I can't see it. Right? You can tell how like they get darker, darker, darker. I can barely see this one, and then this one's non-existent. It's there, right? It's there. It's just so osteoporotic that I can't really tell. But yes, this is multiple compression fractures, not burst fractures, right? They're all still pretty much one piece. They're just a lot smaller than they're supposed to be. Shorter, smaller, yeah. All right, CT or MRI? Excellent. Positive yellow arrow sign. Everybody see the posterior disc bulge. Not as common in the thoracic spine, still can happen, right? And so if this were on a test, and this would be kind of the one that I wouldn't give you the arrow, but this would be one that maybe I would label the thoracic spine so you could appropriately name the disc bulge if you were to see it. Like I would label your T1 through T12, remove the arrow, and just give you the disc bulge and ask you what's the abnormality, right? This is one of the few MRIs I would expect you to find the abnormality in. And really all you do is you just follow, when you got your different colors here, you follow your CSF and spinal cord down and look and see if it's smooth. You can see on the back side, the posterior side, it's pretty smooth all the way down, right? But then when I go anteriorly, I see that bulge right here, kind of pinches in. And so again, you name this for the 2 vertebrae that have the disc bulge in between. So this would be a T6, T7 posterior disc bulge, as it says right there on the slide. Okay? So this could be an example of a thoracic one where I would label it and ask you a question, and then you would have to find it and then name it. Questions on that? That's it for the thoracic spine. Compression fractures, burst fractures, posterior disc bulge. That's about the extent of what you're going to get in this course, and you're not going to get much more than that from an imaging standpoint in the other ologies either. Oh, scoliosis as well, right? But you'll get more about scoliosis in peds because it's more commonly found in the children as they're going through puberty. So, questions on that? All right, let's jump into the lumbar. There's more anatomy. All these spine vertebrae look the same. But again, I'm not here to ask you anatomy questions, but you'll need to know it to understand what's going on. There's your musculature that connects for all of your number one diagnosis of low back pain. Okay, now your normal radiographs or x-rays. Your frontal view or AP and your lateral. How do we count these? So for the lateral, start at the bottom. We know where the sacrum's at. Okay? L5, L4, L3, L2, L1. For the AP, sacrum, 5, 4, 3, 2, 1, count up. For the AP, you look for your last vertebrae that has ribs. We call that T12. We count down, 1, 2, 3, 4, and 5. It's kind of hard to make out where that sacrum starts and ends and where that vertebrae starts and ends right here. So we just go from the top down. Now, there is some patients who have 6 lumbar vertebrae. They won't appear on your exam, right? I can select those patients, they won't appear. But that can happen. So don't let that throw you off if sometimes you get an x-ray and you're like, 6. Go back and count again. Look at your lateral, count it again. And then yeah, some patients have 6 lumbar vertebrae. It's just a genetic thing. I don't know like really exactly why they end up having one. I haven't found anything that says like these kinds of people are going to end up with 6, but some people have 6. So don't let that throw you off, but you will not see that on my exam. Okay, so looking at the AP, so what do we look at here? And the lateral, both of the x-rays. We follow the cortex of all the bones just like we have been, right? Looking for any fractures, any abnormalities. Look at the inside, look at the medullary area, the cancellous bone, make sure everything's looking good. We're checking our disc spaces to make sure they're fairly similar. This one looks a little bit smaller in the L5S1. I will tell you that if they're not having pain in that region, I wouldn't worry about it. A lot of times you'll get, and I don't know if I have it in here because it doesn't really have a whole lot more to the evaluation. They'll automatically give you what's called an L5S1 spot view. So because of the way the spine curves on your regular lateral, the divergence of the radiation automatically makes that look closed off when it's not. So most places have a third film that specifically focuses in on this joint space so you can see what it really looks like, right? So you see what, like, if it's actually open like the rest of these guys. Can't remember if I have that in here or not. All right, and so you're going to do all that. You're going to look at all of your soft tissue. You're going to look at your sacrum. You've got some of the hip down here, which you can't really make it out that well. And then you're going to do the same thing on the AP. What's going on right down here in the pelvis? What's that darker area? Do you know? Gas. Yeah. We'll see what fecal matter looks like. It could be a little, so like the fecal matter is kind of sitting up here, but this main bubble down here at the bottom, that's gas. So you'll see that very commonly. When we get into block 2, you'll really see the difference between just gas and fecal matter when we get into the abdomen, which is no, that's not an abnormality, right? There's air in the soft tissue. Well, that's an area where there probably should be some air in the soft tissue, right? Because it's not in the soft tissue. It's in the intestines. It's in the GI tract. So don't let that kind of get hung up on you. That is normal bowel gas pattern. We'll hit that harder in block 2. Notice how I have a left marker over here. Because can I tell left from right on this? Can I? I can, because I have both sides of the body. So my right is their left, my left is their right. So I could on the spine, if I have the whole thing, know that this is the left side and this is the right side because of my trick of the opposite, right? Remember, the only time you can't do that is when it's like a singular bone and I have no other part of the body to tell me what's going on. If I got a tib fib, I don't know. If I have a forearm, I don't know. But if I have a full chest, I can tell you right from left because I got both sides of the body, and it's always going to be organized that way. Yeah.
So it's like 100% of the time the film will be on the back side. There's no like you stand against the wall facing it, and then it would actually be.
Good question. Good question. No, it's not 100% of the time that way. However, standard protocol for all radiology departments, kind of like how we want to talk the same way with our displacements and describing our dislocations, there's a standard so we're all speaking the same language, right? Same thing with radiological films. There is a standard that before you see the image as the provider, the radiology department adjusts the positioning of the patient in the film to make it that rule. So where it's opposite. Your left is their right, your right is their left. That is the standard of care. So that way we are all looking at the film the same way, we are all conversing the same way, and there's no confusion whether I shot it this way or this way. It doesn't matter because by the time you get it, they will rotate it to the appropriate rule that we have that we've been talking about. So very good question. Which is why we can confidently say that's how they do it, because that is standard across the board. Because especially when we're dealing with something in radiology, you know how easy it would be to make mistakes on left side versus right side if we didn't have some kind of foundation to go off of. Okay? Now somebody asked me this the other day, and I didn't spend a whole lot of time really kind of breaking it down and explaining it too much, because we don't see it a lot with the extremities, we do with the spine, and we will next block. Why is there a left on this side view? What side am I looking at? What side of the vertebrae is this? You're gonna hate me. It's both, right? Because they're superimposed on one another. And I think I might have said it all the way back weeks ago in that first lecture, right? When I have the side view like that of the spine, the left just means the left side was up against the film when they shot the picture. If there's a right there, that means for whatever reason they shot it, the right side up against the film. And that's what's on the picture. It's just there for annotation, right? But technically, this is all superimposed on one another. So if I see a fracture line on one of these vertebrae, I have no idea if that's on the left side or the right side because it's all superimposed. That's where I need my frontal view or my AP to try to match up that fracture with what I see on the side view and go, oh, it's on the right side. So if I turned around and I had something in L4 and I had a fracture here, and I saw that fracture here, that's how I know it's on the right side. The two pictures need to be together. And that would be one of those examples. If I wanted you to tell me what side of the vertebrae was on, of the fracture on the exam, I'd have to give you both. Now, I can give you just the AP, and you can find it and say it's on the right side. But if I give you the lab, I have to give you an AP with it, because these are all superimposed. You can't tell sides on that. Does that make sense? Okay? Most things in radiology are shot as a left lateral where the left side's up against the film. Most of them. Doesn't really change the anatomy in any way for any of you guys. Okay. Here's your CT compared to your X-ray. Now you can see with this patient, look at how open that L5S1 is. This patient's much younger. Much younger. But again, you just trace them all the way through, just like we did our normals. You do the same thing on the CT and just go all the way through, look for any abnormalities. Is this CT with or without contrast? Without, right? I don't have any bright whites anywhere outside of the very light gray with the bone. I can see part of a vessel, like an aorta or something right here, but it's all the same color as the liver, same color as the bowel, same color-ish as the subcutaneous fat and the fat within the belly, right? There's nothing that's highlighted like a Christmas tree. This is without contrast. Here's some more air in the bowel on this side. All right, so there's your normal CT. There's your MRI. Smoother. See the CSF. See the disc space. Have a seat. Don't you take a test. That's not easy.
No, thank you.
Right, so there's your MRI. Compared to your X-ray. Take a look at this. This is not your spine. What bone is this? Well, so an ankle's a joint, not a bone. What bone is this? calcaneus, oscalcus, it's your heel, right? Here's your talus. Here's your tibia. Here's your tarsals. That's supposed to be in 2 pieces. So if I get an x-ray because somebody comes in with foot pain or ankle pain or heel pain or whatever the case may be, and they've actually fractured this. Anybody know the mechanism of this kind of fracture? Like a fall. From how far? Far, right? There's no number to it. This is hard to do. This bone is significantly difficult to break. It is thick, it is strong, and it literally takes from a high height and just falling down and landing on your heels. Not from this. If you do this, you got other issues. So if I see this, what else do I need to evaluate? The spine. That's why it's in the lumbar spine section, right? That energy's got to go somewhere. If that energy was high enough impact to fracture the calcaneus, you're going to believe there's probably some abnormalities in at least that lumbar spine as well. I would just do the whole spine, right? I would definitely do cervical, thoracic, lumbar, but at a minimum, you need to order a lumbar spine x-ray because you're probably going to have other abnormalities. Okay. Looking at more lumbar spine things. Big yellow arrow, but do you see the compression fracture in the lumbar spine? All right, give you lots of examples. Does it look osteoporotic compared to the other side? Right, this is normal. Now understand every patient's a little bit different. But would you consider the one with the compression fracture, this patient maybe has osteoporosis or no? The imaging is going to show it, right? So you can still have a compression fracture without osteoporosis. The imaging don't show it. And I found this image, there was no report saying whether or not the patient was osteoporotic, but I liked it because it doesn't stand out as osteoporosis. These are all pretty good density on all the sides. From everything we're looking at for the normal one, I got your normal comparison here. I don't see it, right? But if I see the compression fracture in clinic, what am I going to do next? I'm going to evaluate for osteoporosis even though I don't see it on x-ray, right? Because maybe it hasn't progressed that far yet. What's my study of choice to evaluate for osteoporosis? The DEXA scan. Not x-ray, not CT, not MRI, the DEXA scan. Right? So, another kind of possible second order, third order type question would be giving you the compression fracture and instead asking you what would be the study of choice to evaluate for your suspected condition. So you got to know it's compression, know that you suspect osteoporosis because it's a compression fracture. Then what do I got to order? A DEXA scan, right? It's not like the entire exam is going to be questions like that, okay? Especially for this first block. But when you start getting into that next class, like the senior class, they start to become much more frequent. So I try to introduce you guys to some of these so you get a feel of what that's like.
Could that be from somebody who's wearing a kit all the time?
Unlikely. I mean, compression fractures are not easy. My guess is, realistically, this patient is probably osteoporotic and it's just not showing on the films yet, which is why I would order the DEXA scan. So yeah, I mean, it doesn't mean it can't happen, right? But in clinic, you would be wrong to just assume that that's what it is and not try to eval for osteoporosis, right? Because then, especially if it's a young person and you eval, you get the DEXA scan and they are osteoporotic, now you got a whole other slew of questions you're asking yourself, which I'll say for endo, like, why? Why are you 30? I don't care if you're wearing gear all day for the past 12 years, right? Why are you 32, 33 and osteoporotic? That's more concerning than the fact that we have this compression fracture. We need to figure out why. What was your question, ma'am?
Those tiny little projections, L3, L4, those are normal.
5, 4,
Okay,
3.
is that normal?
5, 4, 3.
You know, those little, they almost look like.
These guys here?
Yeah.
Yeah. So they could be the start of osteophytes.
Yeah.
It could be. We're not quite there yet, right? But yeah, I could see where that might be something you want to watch, primarily more in L4 than in L3. So she's looking at right here in L4 and in the corner L3. I would say more here. It might be the start of an osteophyte. It's not quite there yet. It's still kind of within the vertebrae. It's not poking out like a little point. But something that you may want to keep an eye on. You're not gonna like X-ray this again in 6 months because osteophytes take a long time, right? So it'll be something you'd be like, hey, let's. If you ever have any back pain, we'll check it again in like a year or 2 years or something like that, just to see if it's getting worse. Yeah, good eye. Other questions on this film? Yes, sir.
I'm just going to share a little story if it helps
Create
a visual. So one of my buddies actually had a compression fracture, but how it happened is, if you guys have ever seen people in training carrying like big heavy logs, like telephone poles, he stepped off a curb carrying it, and naturally, by the mechanics of how the team distributes the weight, he was on the back of the log, and so when he stepped off the curb, the log kind of shocked him and it crushed the thoracic spine or lumbar. So yeah, that's one way it happened. Yeah, so not necessarily just from wearing the gear, right? There was some kind of trauma that kind of caused it, and right, so then again, still my next question would be, if that was my patient, is I'm getting a DEXA because why? Even with that, why did it compress? And the answer might just be it just did. That's fine, but you're wrong not evaluate for osteoporosis if you see a compression fracture. Right? And that could that be this patient? It could be. I don't have the demographics on how it happened or why it happened. Okay? Good stuff. Thank you for sharing. All right. Really, you can answer all three of these questions at the same time in your head, right? Would you consider this, question 2 first, a burst or a compression? Burst, right? Look at, I mean, I got pieces, got a piece there, I got a piece there, I got a fractured up in here, right? I gotta go from both areas. It's protruding posteriorly, right? Most of our compressions, the posterior stayed the same. That's where those lines come into play. When I draw my lines, now all of a sudden this vertebrae is protruding posteriorly into the spinal canal, whereas your compression, it stays put, it just gets smaller. That's being pushed backwards. So that's another hint on it being a burst fracture versus a compression, is that posterior involvement into the spinal canal. Which means we probably have high or low mechanism of injury, high, and trauma, right? It can cause significant neurological deficits and issues. Could it cause paralysis? I'm sure it can. I don't know the incidence of that, right? It probably depends on how severe it's compressing the cord. Did the sharp bone cut any of the cord? I don't know, like that would probably depend on patient, but it can cause significant neurological deficits and probably even temporary paralysis until they can get in there and try to get that off of the spinal cord. Good. Is that a CT or an MRI? CT. Good. All right. Look, I haven't labeled anything except for the big yellow arrow. But I'm confident with sitting in here with you guys that at this point, even without the big yellow arrow, that you would be able to pull out that abnormality with what we've talked about and what we've gone over. You guys have been hitting all the nails on the head pretty much. So first, we'll just say, how would you name it? What is the abnormality on this one where the big yellow arrow is? Bulging disc, not specific enough. I heard some of it. I heard L5S1, I heard L4, L5. Ooh. Sacrum ends here. L5, L4. So L4, L5. Sacrum, S1, L5, L4. Now, if you're not looking at the yellow arrow, I will give you guys credit for L5S1, because if you look closely, I will accept the fact that there is a small posterior bulging disc at L5S1. Do you see it? Yes. All right, the big yellow arrow is L4, L5. But if you were just interpreting this film and I was saying just find me all the abnormalities, right, I would accept the fact that there is a small herniation probably right here. Just based off of tracing, you got the small little bulge. It's not as bad as this one, right? Nice part about this, when my spinal cord comes down, I get my caudate equine and my fibers. Do you think this is causing any significant neurological symptoms? It could, but it's unlikely because there's a lot of room there. Yes, ma'am.
Sorry.
Don't apologize.
Like, is a bulging disc the same
Yes.
Okay.
And I'm sorry if I didn't make that clear. Yeah. So bulging disc is is just a generalized term of the disc is bulging where it needs to be, posterior bulging, right? Herniation, for the purpose of this course, yes. Technically, herniation is when that nucleus pulposus leaves the annual fibrosis, right? But I can't tell that in imaging. So as far as imaging is concerned, whether you have a disc herniation or a bulging disc, either way, we're treating it the same. Okay? Your neurosurgeon, if they're going to go in there and do stuff, they care more about how severe it is and they can do that evaluation. But as far as what we're talking about, it's going to be the same. Thank you for clarifying. Yes, sir.
Is there a reason that we can't see that disc on MRI? Is it because it's bulging? Or
I don't have an answer for that. I don't know why you can't see it on this one. It could be to do with the contrast of the arrow being stuck right in here too, right? When you throw arrows on films, and maybe it kind of throws things off a little bit. I mean, you can see it, and it could be that it is official herniation, and the nucleus pulposus is coming out, right? And it's not contained anymore, because technically that annual fibrosis and that nucleus pulposus, they are two different densities, right? Which is why we get this nice little bright white circle in here. So if it bulges, it's not contained. So it's all kind of the same thing about water balloon. You have the outside of the water balloon and water inside, two clearly different areas. But if you pop the water balloon and put it like in a bucket, now it's all going to be kind of surrounded by the water. So that could be why. But I'm not sure. Yes, sir.
What would it look like at the end of rupture?
Not anything, imaging-wise, there isn't. Yeah, there's not anything on imaging that we're going over that you need to know if it's ruptured or not. Because your treatment for this, which you will learn in ortho and in neuro, is the same regardless if it's a bulging disc or if it's a herniated disc, and it's mostly based off of patient symptomology. If the patient's having pain, they're having neurological symptoms, you're going to treat them. If it's an incidental finding and they're not having pain in that region or radicular pain in the area of the bulging disc, right, because it's L4, L5. So now I know what areas in the legs I want to focus on of where they're having pain. If it matches up with that dermatome, then we're going to treat, and you'll learn the treatments in the other ologies. If they're asymptomatic in those dermatomes, it's watchful waiting. So it doesn't really concern us at that level. Yes?
Would we ever see like an anterior bulging disc?
You can. It's very, very rare, right? It's very rare. Path of least resistance, spinal canal for the disc. So that's typically where it bulges or herniates. Okay. Adult or kid? Oh, adult or kid? Why kid? Because I asked the question. I gotta start asking it to adults now. Look at my sacrum. Look at how it's segmented and not completely fused into one big bone. I still got S1, S2, S3. They're not fused together. That's the same thing as like the physes and the growth plate. No, you can't have a Salter-Harris fracture of the sacrum. Right? That's all going to become one bone. No, you cannot have a Salter-Harris fracture of the sacrum. I'm not going to make you pick out a spine for kids or versus adults or anything like that, because we haven't really covered any differences between adults and kids for these abnormalities. They're all the same. I just wanted to point out that it is a kid because the sacrum is still segmented. So now that I pointed out where the sacrum is and avoided the confusion of the segments of where's what, how do we name this? Sacrum's here. So here's S1. Keep it in the back. Sacrum's here. Here's S1. So 5, 4, 3, 2, 1. 5, 4, 3, 2, 1. So we have an L5, S1, anterior spondylolisthesis. Everybody see that? L5, S1, anterior spondylolisthesis. All right? Questions on the spine? Ask them now or at the review. Okay. All right, let's jump into the pelvis for a little bit. There's your anatomy. There's your pelvic ring. Why is that pelvic ring in that circle important? Because we're going to talk about when we have concerning injuries and where it's fractured and why the pelvis is so important when we're doing trauma evaluation. But definitely know your anatomy on this one. Here's another picture of the anatomy with all of the ligaments that kind of hold everything together. Here's what it looks like on x-ray, annotated for you. Now that we've seen it, if you remember way back when we went to that ankylosing spondylitis, right? That pubic symphysis was all one bone here, right? It was all fused together, right? So this is, I didn't have a good one back then to kind of show you what it should look like, but you should have this nice, what almost looks like a joint space. It's not a joint space, it's just a cartilage in between there in the pubic symphysis area. But when you get that ankylosing spondylosis or spondylitis patients, you end up with that being fused in those severe cases. Same thing with the SI joints. Focus more on the sacroiliac joints. This nice little joint here. This is where the sacrum meets the pelvis, right? And so those are areas that you want to keep an eye on. Those are not fractures. Those are your SI joints. Normal to have bowel gas in that area. There's a kid that would not be giving you children pelvises, but you may see them in clinic. Those are not fractures, these are normal. Things have not fused yet. And they fuse at different times. It's too confusing to know when it's supposed to fuse, when it's a fracture, when it's not a fracture, when you're dealing with all of these joint spaces and the rami and the ischium and the pubis and all of that. So we save that for the specialized radiologists, but you may end up having to look at these at some point in clinic. Frog leg view. So this is our version of a lateral pelvis. We don't really get a lateral pelvis. It's not going to show us a whole lot. That's superimposing a bunch of bones and anatomy, right? So what we do is we do our frontal view or our AP with the legs straight down, and then we just ask the patient to pick their knees up and lay them out to almost get like a lateral view of the hip, which we'll look at in the lower extremity lecture, but we do it with both sides, because we want to see that everything looks the same from side to side, and that's the version of the lateral view kind of the pelvis. Whenever you get a pelvis x-ray, you get the AP and you get the frog leg. Legs lay out like a frog. Here's a CT slice. Oral contrast, right? Because that's bowel. So all the contrast is within the intestines and within the bowel. We can tell by the loops. We'll get more into that in block 2. Primarily for this block, you're going to focus on, if we get a CT, the bony area and the soft tissue, not so much the contrasty bowel area. Block 2. Okay. Pelvic fracture. A lot of words on this slide. It's dangerous, it's scary, you have to evaluate for it. The key area that you need to definitely focus on is the right side of the slide with the imaging. I have 3 different imagings here, all based off of what's going on and what status the patient is in, right? So, pelvis x-ray is always the initial study in the trauma bay. They're going to come in. It's going to take time to send them to the CT scanner. It's going to take time to get the ultrasound machine for the fast exam. You're knocking the x-ray out because if they come in trauma, somebody said it the other day, right? Chest x-ray, abdominal x-ray, pelvic x-ray. Everybody gets that out the get-go when you come in for a trauma. Just to make sure there's nothing significant that we can find right now very quickly that could end up killing the patient if we don't fix it, right? You'll get to the extremities later, but chest, abdomen, pelvis, x-rays, go. So pelvic x-ray is always going to be your initial study. It's going to help us find any of those major fractures that we need to know, because if there are a bunch of fractures, depending on where they're at, it's going to tell us whether this patient could be stable or unstable on top of their vitals, right? Then the question becomes, what do I do next? Do I do a CT with abdomen and pelvis, or do I do a fast exam? Are they stable? If they're stable and you don't have to wait very long, get the CT. Because the nice part about the CT, and this will end up being with contrast, again, we'll focus contrast stuff a little bit more in block 2, but you just need to know CT abdomen and pelvis for this one. We're going to be able to find any kind of bleeds on there. We're going to be able to evaluate the bony part of the pelvis really well. We're going to do the abdomen as well. So like I said, the internal bleeding, the organs, the liver, the kidneys, the spleen, the intestines. We're going to be able to see all of that, right? And really truly know the extent of the damage and the injuries by getting a CT abdomen and pelvis. We will see urethral injuries on the CT if we need to, depending on kind of what the exam looks like. But if I can't send the patient to CT, I need to do a fast exam. Because they're not stable, I'm going to throw the ultrasound probe on it, and I'm going to look for any abnormalities and any bleeding. Okay? Know that there's going to be a flow chart here. I'll put it on right here. Know that flow chart. Okay? X-ray always initial. If stable, CT scan. If not stable, fast exam. If they come in a pelvic binding device, which isn't used very often anymore, but if they do, you're just doing a fast exam. Because that means that that's an unstable pelvis, and we'll talk about why after you come back from break. Go ahead and come back to the top of the hour. This slide is a little bit confusing, so let me kind of clarify it. So this is supposed to be a flow chart, kind of talks about what do we do, pelvis fracture, CT scan, or fast exam, which we are going to cover the fast exam a little bit here soon of what it actually is and what we're looking at, okay? This plus or minus pelvic x-ray. What that's really meant to do is the initial test is the pelvic x-ray, right? If for whatever reason the patient rolls in, it's a busy trauma center, that kind of thing, if the CT scanner is available, or your EFAS is available on somebody who had a trauma, a pelvic trauma, you're not going to wait for the x-ray to progress down this algorithm. That's what that plus or minus means, right? You're not going to wait for the x-ray. No, the CT's ready. No, we can't send the CT yet. We got to wait for the x-ray tech to get done in bed 3 to get this pelvic x-ray. No. Send them based off of stable, unstable for any pelvic trauma to further evaluate based off of the flow chart, okay? Your initial is still your pelvis x-ray. So if I were to ask you what the initial study is going to be for anybody who comes in with a pelvic trauma, it's going to be pelvic x-ray. Your follow-up study or study of choice will depend on stable versus unstable, CT versus fast exam, and that's what that plus or minus pelvic x-ray means. Don't wait for the x-ray to progress if available and the x-ray is held up. Does that follow? I know that's kind of confusing looking at it there. Yeah.
I mean, so I worked in ER for a long time, and like anytime a trauma would come in, your X-ray tech's going to be there with the mobile X-ray, and then they're going to get a fast exam, regardless of like necessarily a mechanism. So like the doc's going to do the fast exam while the X-ray's getting set up, and we're doing all the other things, and then we roll the CT.
In a perfect world. But I don't know what facility you're going to be in. And being a former rad tech, what I can tell you is I might get that call for that trauma down in the ER, but I might get that page as the trauma's rolling in, but I can be fully gowned up, contact precautions up in the ICU right now. And it's going to take me 10 or 15 minutes to get down there because I'm in the middle of doing something else, and I can't just drop to answer the page because I'm all gowned up. And so that's kind of what I'm making the point. You're right, all these things happen simultaneously, right? When you're in the clinic and you're gonna see this, it's like, there is no like, well, we're waiting, like it happens fast in a trauma, right? But we have to teach from an algorithmic academic standpoint so you understand the difference between the stable versus unstable in the x-ray. But you're right, it doesn't happen at the same time. But sometimes that x-ray tech won't be there. Now,
I mean, we were lucky, there was always like an x-ray tech that was like,
assigned
hey,
to the
you're
ER.
the trauma.
Yeah. And some places have enough manpower to go ahead and do that, right? And that's awesome. A lot of places don't, especially wearing the uniform, because as you know, we're short-manned everywhere. Like, so when I worked at Travis as the rad tech, we had 2 rad techs on at night from 7 p.m. to 7 a.m. for the entire hospital of David Grant, which had 3 inpatient wards, an emergency room, surgery, all of that stuff. So we weren't assigned to the ER, so we could have been anywhere in the hospital. And then if you're in that situation, then this is where you would go if you can't get the x-ray. But you're right, a lot of the stuff clinically happens simultaneously. Because I talk about this stable, unstable, pelvis, right? EFAS versus CT, he's 100% right. If they're unstable, they're gonna get the EFAS and the pelvic x-ray. That CT is still it's still coming, right? Later, once the patient's stabilized. Right? But this is more for you to make that decision right now. What's the imaging I need to do first? based off of what's going on with the patient. Because they're still going to get that CT down the road, even if they're unstable now. Because there could be other injuries not in the pelvis that I can't see, but I need to focus on getting them stabilized first. Okay, so let's talk about other injuries of pelvic trauma. We talked about the pelvis a little bit. We'll look at some x-rays and see those fractures. But there are other things in the pelvis that could be injured, right? Bones are sharp, trauma happens, bladder ruptures, very common with pelvic fractures. Why? The bladder sits right there, okay? How do I evaluate for that? CT cystogram. That's what you need to know for bladder imaging. CT cystogram if you're concerned about a bladder rupture or bladder imaging. Now, how can I know if I'm concerned about a bladder rupture? Well, we're going to find out when we look at those fast exam pictures. Okay? Urethral injuries, also very common in pelvic trauma. More common in males than females. Why? The longer urethra, there's more of a chance of it being injured, right? So a lot of times you're going to see this on physical exam with that blood at the urethral meatus. If there is blood on a male or a female at the urethral meatus after a trauma, you should be concerned for urethral injury. The retrogram urethography is the study of choice. We will look at some of those pictures and kind of see what they look like. I'm not going to make you interpret that, right? We're going to see what abnormal is, but you need to know what to order if you're concerned about an injury in that area. This is what we're talking about, stable versus unstable pelvic fractures. Yes, the vitals will tell you if a patient is stable, but so will the fractures of the pelvis. You can have a fracture anywhere in the pelvic ring in one area and it's considered a stable pelvis fracture because the rest of the ring is going to hold it all together. So if there was no fracture here and it was just, in the sacral area, because this is the SI joint here, right? Here's your SI joint. So if it was just in the sacral area and this was all still together, that would be a stable fracture because the rest of this ring is going to keep things in place. Once I fracture in two areas of the ring, it becomes unstable because now I have two floating pieces of the pelvis. And that's what that picture of that person was checking. Can I move the pieces of the pelvis? They don't recommend doing that anymore because we have found that it can cause more damage than good, right? But that is what that old school way of kind of playing with the pelvis to see if it's stable versus unstable. So, fracture in one place, stable. Fracture in more than one place, 2, 3, 6, 12, unstable. Okay? This is just an FYI slide because sometimes what you can see, especially in our older patients, is an avulsion fracture right here along the ischial tuberosity in non-trauma settings. See the red arrow? Compare it to the other side. When you follow your cortex, you're smooth, and you can see the break right there, break in the cortex, this extra little fleck of bone, looks like it's just peeled off of the ischial tuberosity. That is a common avulsion fracture area in the pelvis. Usually from the hamstring, right, or the iliopsoas muscle working out, fold it, kind of hold it off a little bit. No, not seeing it.
No, I see it.
Okay, if you hold it up higher, it might work. All right. Oh, you're trying to get a signal? Yeah, good luck with that. I walk out of this room, my phone blows up. Okay. Don't commit brain power for my exam on this. But when you get into some of the other ologies, your types of pelvic fractures could be important. I'm just presenting it to you now. There are different types. I only care about stable versus unstable. That's what I care about. Here's a good link for some pelvic imaging where you can actually scroll through and find the fracture. Has anybody tried to use Radiopedia for like CTs or MRIs yet? Right? It's really cool because you can actually, I keep talking about, you can scroll through and look at the whole study. You can actually do that on Radiopedia, so it gives you a true representation of what a CT or an MRI looks like. You can do that here with the pelvis here and that one as well. And so you can kind of find those abnormalities and kind of see all the slices. Unfortunately, I tried, I can't give you that on the exam. It limits me to just a picture. So if I give you a CT or an MR, it's going to be just a slice. So you just have to go with the information that you have in front of you, and don't make things up. If it's not there, or it's not in the vignette, don't assume and put it in the vignettes. If I wanted it to be in there, I would have put it in there, right? I don't want you to make up your own information or your own, well, the next 3 slices down, I think it might show that. If it's not there, it's not meant for you to create on your own. I will give you all the information you need. Don't make up your own. Okay? All right. So now let's look at the normal pelvis on the left. Go through your methods. I pointed it out on the right. Okay? Primarily on this one. Should be a couple that stand out. I put the arrows there for you because we're still kind of learning it and going through it. But the fracture is right here in the superior ramus. I follow my cortex, I look at my normal. I should have this nice smooth circle here, bones all connected. Look at my tuberosity, everything's good. When I look down here, I got this gap right there. Okay, that's number 1. So right now I'm like, okay, I have at least a stable pelvis fracture. But now I need to look everywhere else. Now I don't even need the normal here, but here is the normal for you, because a lovely part about a pelvis is I get 2 sides. So when I follow my pelvic rim around here, it should be a nice, wonderful circle, SI joints up into the sacrum, coming on down. This side looks a little funky, but it's probably because of the fracture here. I follow it here, here's SI joint number 1, and then what? Right, like it comes down, and then shoots up, and then comes back around. That is not smooth, right? So part of that, 1 of 2 things happened here. Likely what's happened is the ilium went superiorly, right? I can't tell for sure, I don't know, but you can tell that the sacrum sits here, and then here's where the rest of that ilium is. So these should be smooth like it is on this side. So there's my second fracture. It's actually a SI joint dislocation because the sacroiliac is a joint. So it is dislocated. Don't get hung up on sublux or dislocated with the SI joint. We call everything with SI joints dislocations, right? Not gonna, if I'm asking you sublux or dislocation, it's gonna be a different body part. It's not gonna be the SI joints. So don't get too hung up on that. But that makes it an unstable pelvic fracture. 2 areas, unstable. Yes, sir? Most of them, no. Most of them, no. I try my best to make them as clear as possible. I really do. I've changed pictures out quite a few times to try to make them better. Unfortunately, sometimes when I'm trying to find a certain, because here's the challenge with picking pictures for your guys' exam, right? Is finding a quality picture that only shows the abnormality I want you to find. Because you've seen how many of these things have multiple things going on, and I want to draw your attention to one thing. So where I run into a challenge sometimes is trying to find high quality images that only show that. So I do my best. If there is a blurry picture, like this one, right, the question will be worded in a way to where it's you can see enough to be able to get to what you need to get to. Like there won't be something like hiding here, and I'm like, oh, well, haha, there was a fracture. Like, no, you can't see it, right? So I'm not going to do that to you. So if it is blurry, it'll be enough abnormality to be able to pick it out. Yeah. I know, I wish I could pull over actual images, but it's, as I was telling somebody else, the way the system is set up, it's too difficult for the quality. Here's why we try to get that CT. Not the same patient, right? But if I go back here and I look at these fractures, I'm like, yeah, I don't really know how impacted or how severe those guys are. But the CT really shows me how impacted, right? So we got the sacral fracture here, because this is the SI joint. Here's the SI joint. Here's my sacral fracture. Here's my left ilium fracture. This is an unstable pelvis. This is a normal CT. Soft tissue window. This is that bone window we talked about, right? Look how nice it shows the bone up. Kind of hides all this other stuff, but it really makes the bone pop. So this would be unstable because I got 2 different fractures in 2 different areas of the pelvic ring. So, everybody see that? Okay. This is that open book injury, right? So no fractures through the bones on this. No fractures through the bony part of the pelvis. What we have is widening of that right SI joint. Look at how wide that is compared to the left side. This is how it should look. This is how this one looks. And then look at my pubic symphysis compared to what it's supposed to look. This is 2 areas of disruption, unstable pelvis. So this is where someone's asking me, hey, about like the anatomy of the pelvis, you know, that kind of thing. Like, this is where it becomes important, is understanding the anatomy of what is where. So if you did your method of, for the bone stuff and the cortex and the medullary and everything, there's no abnormalities here. And it's not until you get to that joint spacing area that these things start to jump out. So you got to go through that methodical process. Now this one, big shiny toy, right? Oh, that's not good. Don't miss that because you look at the big shiny toy. Because the difference between missing this and not missing it is diagnosing with a stable pelvic fracture or an unstable pelvic fracture, and that can be significant. All right, I'll let you guys do this one. Take a look at it. You want to say it out loud, just take 30 seconds. Take a look at it. See if you can find the concerning areas. For those of you who have the PowerPoint and not getting converted to Notability or PDF, don't cheat and look at the notes. At least until after you're confident you found the abnormalities. All right. So I'll show you now what I see going through it. So the first thing I definitely see is my right SI joint widened. Right? That is large. How do I partially know it's large? Well, look at my left. Look at the size of my left SI joint. A, I've seen enough of them, and then B, that is not the same size. I also have a left sacral fracture. Right? Ilius, or ilium, sacrum is after the SI joint. So there's my SI joint, this is all sacrum. So those are the 2 abnormalities. I have a left sacral fracture and a widened right SI joint. That makes it an unstable pelvis. How about this one? Stable or unstable? This one's a little more challenging. So, big shiny toy, right? I know you all saw that one. I know you all saw that. Can you see anything else? And no, just because I'm asking doesn't mean it's there. It might be, it might not be. All right. You ready? Compare it to the left side.
Oh.
Look at my spacing here. That's a sacral fracture. SI joint ends here. Look at that gap right here. It's subtle. I will admit that it is subtle. What's this guy? Anybody know? What is that guy? It's not a stone. Stones aren't usually that visible on X-ray because they're so small. They can be. We talked about it way back when, very briefly. Remember those normal things that can show up in like veins in the vessels? Phlebolyths? That's a phlebolyth. Very common in the pelvic ring. Yeah?
Patient's left up top, is there a break in the cortex on the unison? Or am I seeing that black? Oh, I'm sorry, the patient's left.
Or your patient's left.
Is there a break in there? Is that? Nothing.
That might just be from the bowel gas. Let me look better at my screen. Yeah, that's just the way it's projecting on the screen.
Okay.
If you look at your screens, you can see the cortex, I think, a lot better behind that bowel gas. Can you take a look at your screens?
It looks like a big.
Yeah, it's not a break, but good. I like that you're looking for it, but no, that's all the way through there. That's good. Yeah. So this right here, that's going to be just the way it's projecting right now. So sacrum comes in, and usually it's going to, there's your sacrum down here. So yeah, it could be another hyperlucency. I don't have anything in the report that shows that was an abnormality. Yes, ma'am.
I know you said that stable versus unstable is one versus many.
Yes.
If they have open pelvis, open, and if you don't see the other deformities, are we considering that stable or unstable?
Clinically, the odds of this happening with the pubic symphysis and there not being something else making it unstable is super rare. Right? So if you see a wide pubic symphysis, you should then be going, where's the other one? There's something. Yeah. Because this doesn't typically happen by itself. All right, how about this one? Take 20 seconds on this one. All right, ready? Right here. There's a right acetabulum fracture. What's the little divot here in the femoral head? That's the fovea. That's normal. That should be there. This should not. Off of this image, right? It's a CT. You can't say stable for sure off of this. I couldn't ask you stable or unstable on this particular image, primarily because of the fact that you don't have the whole pelvis in front of you. That's unfair, right? That's unfair. You're CT and you see it all. These are reviews for you going back to that focal increase of bone density. Yeah, remember those avascular necrosis things? I throw these in here so that way as you're going through, you're like, oh crap, I don't remember that. I need to go back and remember those things. Not for here right now, but for like when you're studying. Same thing with the generalized decrease in bone density. These are all the bone density things from like what feels like 6 weeks ago, but was earlier in the week or late last week. What is hemarthrosis? Right, medical words, hemarthrosis, so bleeding within the joint. And we look primarily at what body part we talked about that? The elbow. And what was a telltale sign for knowing that there's a fracture because of the hemarthrosis in the elbow? So two of them, right? The anterior sale sign or primarily the posterior fat pad. If you can see the posterior fat pad, you know that there's something going on. We're going to see that again in the upper extremities. Complete versus incomplete. All the way through the bone, or just through part of the bone. When a tendon pulls a piece of bone off of somewhere, that's called what? Torsion fracture. Non-union, malunion, we talked about that yesterday. Questions on that slideshow? Sir?
Going back to your patient stable, unstable algorithm.
For the pelvic fractures?
No, well, yes.
Okay.
Pelvic fractures.
Okay.
Are you going to tell us if the patient is stable or unstable? I know how we diagnose the stable, unstable, but are we just going to give it vital signs and us guess if they're stable or unstable?
So if I give you vital signs, it shouldn't be a guess, right? Vital signs are fair game, right? Because we know what normal heart rate, blood pressure, respiratory rate, all of that stuff is. So yes, there will be vital signs in the vignette, and that's what will tell you if the patient is stable or unstable.
Okay.
Some of the questions in the past, right? You gotta know how many different versions of exams we have. Some questions do say stable or unstable, and some of them are just vital signs. And correct me if I'm wrong, because nobody's even brought this up to me before, so have I been doing a disservice? Have we learned normal vital signs at some point through IPAP so far? Okay. I forget, it's been like over a decade since I came to the program, and they've moved stuff, right? So yeah, so vital signs, if I want you to know a patient is unstable or stable, I will give you vital signs to help you distinguish between those things. Right? Somebody who's got a heart rate of 125 and a blood pressure of 85 over 55 and his respiratory rate is 24, that's not a stable patient. Don't send him to CT, they'll die. It's not a stable patient. All right, let me shift real quick. I think we only have 2 slideshows left. You're like, only 2, you're like 114 slides each. But, we belabored a lot of these abnormalities already, right? That's why I spent so much time on some of those other things and pointing them out. So when we get to this specifically, they're like, hey, we talked about this. Now here's what it looks like. Here's what we call it. Questions, right? So that way you have that foundation now. This is what I'm talking about. A lot of times you can diagnose a patient before you even send them an x-ray. All right? What do we think happened with this patient? Possibly a dislocation, right? That's what's on my mind. Where, how bad, what direction? I'm not sure. I mean, I can probably tell you from looking at it, but there's your dislocation. Is it anterior or posterior? I can tell, hey, we can't tell. Which means on the exam, if I wanted you to tell me if this is anterior or posterior, I have to give you more than one picture. I can't just give you this and have you tell me. This is for your toolbox for when you get in the clinic if you ever need to reset or reduce a dislocated shoulder. Right? You're going to see this again in ortho, but I've used this slide specifically in my clinic before, so I threw it in here for you guys to have, and I actually got it from when I came through this program in ortho. So I was like, oh yeah, I still have that on my desktop. Okay, so this is going to be upper extremity. We're going to go clavicle shoulder down to the hand. Look at all the different abnormalities you need to know about. Look at all the different x-rays. Clavicle down to the hand. There's your bony anatomy. You gotta know your bones. Because yes, if there's a forearm question on the test, you'll probably have choices that are radius and choices that are ulna. Gotta know your bones. Let's start with the clavicle and the AC joint. Okay, there's your anatomy. There's your musculature again. More specifically, your deltoid, latissimus dorsi, the trapezius, very commonly a source of a lot of pain in the AC area. And here's our x-ray. Okay, so first thing, before we evaluate the x-ray, I want to draw your attention to this 30-degree thing, okay? So the reason that's on there, and you don't need to know to order it this way or what to do, this is a natural thing, is this is telling you, because everything we've been talking about, the x-ray has been shot straight on, right? The patient's standing, they shoot an x-ray, and it shoots straight. We've been talking about that the whole time. This is telling you that they took that x-ray tube and they angled it upward 30 degrees and shot it this way, intentionally to project the clavicle above the rest of the shoulder joint area to get a better view of it, right? So they tell you that, so that when you look at it, you go, well, that doesn't look like the standard thing. Yeah, it's because they did that on purpose for you. You'll get used to seeing that because that'll be part of your protocols when you get to your base, okay? Every base or every hospital is a little bit different. but they'll have a book of when you order a shoulder x-ray, what do you get? What do you get when you order a knee x-ray? What's the standard at that facility, right? And you'll familiarize yourself with that. So, but more importantly, look at the clavicle, right? So we have our sternoclavicular joint, we have the main clavicle, the AC joint, and the acromion process. This is a normal radiograph. How do I know it's normal? I do my cortex, no abnormalities, look through my medullary area, no abnormalities, my joint spacing, which you will learn as time goes on. And yes, it looks a little projected up, right? Well, it told me it's 30 degrees up, so I'm not surprised that it's a little bit more projected than what it should be, because it was projected up at that 30 degrees. That's why that's important for you to know as a provider. Okay, pictures from last time. So when it's straight on, look at that red line I put in there. Look at how it lines up very nicely as your joint alignment. But when I do that 30 degrees up, you do get a little bit of separation there from that line because of the 30-degree cephalad angle. If this is not annotated on here and straight on, this becomes an abnormality because it should look like this. Okay? Understand where your acromion is, and that comes up to the clavicle. Understand where your coracoid is. Understand that the coracoid is different than the coronoid. Words are important. Where's the coronoid at? Do you remember? In the elbow area, right? But the coracoid is up in the shoulder. Don't get those confused. Read the words. Humeral head, right? Glenoid, clavicle. Between the acromion and the coracoid is the spine of the scapula. That's what that is. That's what SS is. It's all in the notes there if you want to look at it. But that's a normal radiograph. So here, this one, they decided to do 15 degrees cephalad. It doesn't really look like that much of a difference, but thanks for letting me know, so that way I know if there was a little bit, I'm not too overly concerned. More importantly, we've seen this picture before. This is our clavicle fracture. Here I put the description down there for you. Right? Common unit is okay. You can use the butterfly or segmental fragment, that's okay. The biggest thing, it says mid-distal shaft because it's in that gray area. On the exam, you will either have mid or distal. If it's in that gray area, I won't give you both. If it's clearly distal, like it's out here, then you may have both. If it was like out here, you may have both as a choice. But if it's in a gray area, you're only going to have one of the two. Okay? Not here to trick you in that aspect. But again, we have inferior displacement because we name it for the distal segment in comparison to the proximal segment. So the distal segment is inferior compared to the proximal segment, so that's why it's inferior displacement. Your eyes want you to think that this is moved because look, the clavicle is right in line with the acromion here. So your eyes want you to think that the issue is here and that it's superior displacement. It is not. It is inferior. Always named for the distal segment. Here's a distal clavicular fracture. So I was talking about if I go distal. Now, if I had one of these pictures on there, a mid clavicle fracture is a fair option that is clearly incorrect because of where the fracture is at. Does that make sense? Okay. Again, inferior displacement. Okay. We've had this one before. What type of fracture is it? Simple or common unit? Simple. Whereabouts? Mid-shaft. What bone? Clavicle. And apex what? That's good. Start reading your own films. You got this. You got it. You got it. Whoa. What do we have here? So we still got mid-shaft, right? So I'll tell you what this was, right? I'm not going to make you pull this out. This was a malunion. that was causing issues, so they went in and refractured it to try to get it to heal right. So you can see kind of where the malunion was in this area here. A lot of clavicles, especially in adults, will heal non-anatomically and will become malunions. But also a good portion of them don't have to be refractured because the patient still has full functionality. They just got a funky bump sitting up here and it doesn't affect functionality. This patient it did, so they had to go in and refracture. This was the x-ray right after they refractured it. It's still mid-shaft. That's the clavicle. Know how to describe where the fracture is. If there's an apex, right, you'll be able to pull that out, and that's your clavicle. AC joints. How do we hurt our AC joint? Well, you can fall on the outstretched hand. I know we talked about the wrist and the skateboard that way, but it can affect the AC joint too, especially if you don't bend the elbow when you fall. Direct trauma or the top of the shoulder, or shoulder acromion with the arm adducted. Adducted, right? Not abducted, adducted. What are your symptoms? Tenderness and swelling over the AC joint. I would venture to guess there's a good portion of people in here who have had some type of AC joint sprain or injury in their career or in their life. And those who have had will tell you this hurts. This hurts when it happens. Like, it is not something that is like, oh, well, maybe. I mean, and you can push right on that AC joint and you will cause significant pain. You're getting a few head nods from those who have had it, right? So this is pretty easy to diagnose physical exam-wise where you don't even need imaging, but you're going to get it because you want to see how severe it is. Pain on lifting arm. X-ray is your study of choice, but you need to do it bilateral for comparison with weights. With weights. So there's sometimes what it can look like in some severe cases. It might not be that severe, right? It might be more minimal than that. But that's not the same. Right. Here is the difference of a normal radiograph just in itself between without weights and with weights. Okay? So what I want you to look at is look at the AC joint here where I got the without and the circle. Okay? Now, what is a weight with an AC joint? What happens is they take the picture with this, and the patient is just standing. Then they hand the patient 5 pound sandbags usually, or 5 pound weights, and you hold them, and then you relax your shoulders and you drop them. And it pulls the shoulders and the arms down, causing a little bit of a larger joint space. To take a look at that joint space and see it open up a little bit. So this is with weights. This is without weights. So look at the difference on the normal. You can see we expect to see a little bit bigger of a joint space between the without and the with. Okay? This is not an abnormality. This is normal. That is an abnormality. Look at how little it changed on the normal when everything was intact. And look at the comparison when it's not. This is why we do it with weights, because this looks fine. This without weight looks like there's no major issue with that AC joint. Once I hand the patient weights and do it again, look at the separation. So AC joints should always be bilateral and with and without weights. I cannot think of a situation where I would not order an AC joint with weights. Because you don't get a true evaluation. You will miss a significant injury if you don't do it with weights. So you do both. Sometimes you can have osteoarthritis of the AC joint, probably in those patients who what? Had this and have had injuries. Right? An AC joint is not a common area to get osteoarthritis, but you absolutely can have it. And where you start to see it again, my normal spacing. But now I'm starting to get narrowing, and look at my osteophytes where I had little circles there. I got the osteophytes kind of starting here compared to what the clavicle is supposed to look like. This one's even more severe. It's almost got the whole joint almost kind of fused together. It's not actually fused, it just looks like that because of how severe the osteoarthritis is. So you can have osteoarthritis in the AC joint primarily in people who have a history of AC joint separation, AC joint injuries, that kind of thing. These are just more pictures for you to look at what happens between the normal and the abnormal. What's the difference between this one with the abnormal and the other one that we've seen where it wasn't lined up nicely? I don't have that note that tells me it's 30 degrees cephalad or 15 degrees cephalad, right? I don't have that. So I should have that nice line. I don't. This is abnormal because I don't have that annotation. Here's what an MRI looks like. This is the AC joint. You can see that it doesn't really give us much more information right now. The only people that are going to order MRIs on the AC joints typically are going to be your ortho folks if they're considering surgery or not. You'll learn more about that in ortho. There's multiple types of AC joint injuries. Do I have it? Yeah, okay. So you don't need to know this for my test. You will need to know it for ortho, right? But it breaks down. The type 1 is the sprain, type 2 is a tear of the one ligament, type 3 is a tear of all three ligaments. Okay? So you'll learn that in ortho because some of these are surgical, some of these are not. A lot of them are not, depending on the severity. I labeled that for you guys, even though you don't need a right marker to be able to tell. But which side has the abnormality? The right side. Nice, normal flow, good joint spacing, gap, not together. Joint not lined up. So it is the right side. Take a look. I think this is with weights too. Let's see what I have. Yeah, just as right AC joint separation. I'm pretty sure this is with weights. What's this guy? You remember? Acromial. Remember that normal variant that we talked about on the shoulder x-ray? Acromial. How do we confirm that that's a normal variant? Do the other shoulder. Right? That's a segue into the shoulder. Questions on the AC joint? Know how to find the abnormality, know what to order. Shoulder anatomy, we just saw this. It's there again for you. More muscles. Stuff you already knew. Here's what the x-ray looks like. Okay. What's really important when it comes to shoulder x-ray, besides all the stuff that we already talked about, is remembering on all these images which one is the acromion and which one is the coracoid. Which one is the acromion and which one is the coracoid. And the reason I say that is you're going to use that with some of these other images, primarily the one that kind of looks like this, to figure out if it's an anterior or posterior dislocation, and we'll get to that. So, but don't overlook all of the anatomy on the image. You've got to do your method and do your system of looking for any abnormalities, okay? So, there's a lot on this picture. So let's think about the exam for a second. That's 50 questions of looking at pictures, right? It won't be 50 questions of pictures. There will be a decent number of non-pictured questions on there. But you're like, how the heck am I going to read all of this on all these pictures and do it in time? Look at your answers first. Let your answers guide you to what you're looking for. If I'm not asking you about lung pathology or any clavicle questions or rib questions, then that's probably not what I need you to focus on for that question. So I say for my test, if you look at the answers first and know what you're looking for, it will save you time when you're analyzing the image. because you'll know what you have to rule in or rule out. Okay? In clinic, you gotta take time to look at everything because you're responsible for everything that's on the picture. But for the exam, you're timed. Right? In clinic, you're not necessarily timed. You can look at the X-ray whenever you have a minute. Okay, so here's another labeled picture anatomically of the shoulder. Give you a bunch of these so that way you kind of help see it and understand where things are at when you're going through and studying it. You see, normally this is how I do it. I can draw on the slides, but the thing has been like, the calibration's off, so I can't do it. So I'm using the laser pointer and I save some of these, so it'll work better. All right, so you have your AP view, okay, which we've already looked at here and here, right? We've seen the dislocations for that. There are two potential images that can tell you whether or not your shoulder is dislocated anteriorly or posteriorly. One of them is the scapular Y view. They call it the scapular Y view because the scapula looks like a Y when they shoot it this way. All right, it's done at a nice little 45-degree angle to get the scapula looking at a nice pretty little Y, and the humeral head should sit right in the meat of the scapula, right in the main part of the scapula is where it should sit. This is normal. The nice part about this is, if it's dislocated, the humeral head's either going to be back here or up here. If it's up here, it's in the thorax. I'm on the side, right? I'm taking the picture kind of from the side. So if the humeral head is projected in the thorax, in the lungs, it's anteriorly dislocated. If it's projected back here, it's posteriorly dislocated. This is that additional image you need to try to figure that out. There's one of them. Okay? So again, when you understand how the patient's positioned, right? Kind of like that side view, that lateral view, makes the scapula look like a nice Y, the humeral head sitting right there. If the humeral head is in the thorax area, which is this way, it's different from how the patient's standing, right? That's anterior, because it's being projected in that rib area. Back here, it's posterior. This is normal for both of the images we've looked at. Neither one of these are dislocated. Does that make sense from a positioning standpoint? Right? An AP is enough to tell me, oh, that's down here, I think it's dislocated. But I don't know where unless I have a scapular Y or what's called an axillary view, which we will also see. Which is right here. So this is your axillary view. So now I want you to look at normal. Look at this, coracoid and acromion. Right? It's important to know which is which and where each is. It's going to come into play in a minute. Acromion, coracoid. Acromion, coracoid. Okay? This is your axillary view, so they can either shoot it underneath or through the top, depending on patient comfort. Doesn't matter, you get the same picture. Okay? They'll flip it to the way it needs to flip. It doesn't matter, you get the same picture. But I want now that you see the normal, what it's supposed to look like, I'm going to go all the way back to that guy. Pay attention here. Okay, where that ossa acromial is. It's not there. This is a normal axillary view. Now, the problem with this particular image, if you dislocated your shoulder, how well do you think the patient's going to be like, sure, go ahead and take my x-ray, right? Very challenging to get. Sometimes they do. Sometimes they're creative and they can get it. But that's why a lot of times you'll see the scapular Y view in true shoulder dislocations, because this ain't happening for a lot of those patients. It is way too painful. So that's why we have the two that can do it. But you will sometimes see that. Okay? So, you don't have to worry about this, but people ask, what is this? This is an MRI. It's a labral tear from a dislocation that got reset. Okay? And up here, we'll talk about it more later. That's a fracture of the humeral head from a dislocation that got reset. We'll talk about those fractures a little bit later on. Okay. This will be the last slide of the day. This is why knowing the acromion and the coracoid is important. Based off of where the scapula is on what part of our body? Posterior. So the acromion is posterior. The coracoid is anterior with my clavicle. So if I have a humeral head that's not sitting pretty and it's over here, that's a posterior dislocation because it's over the acromion or behind the acromion. If it's past the coracoid and it's over here, it's an anterior dislocation. Right? This won't be labeled on your x-rays. It is here for you to kind of put it in your mind's eye, right? So that's why I say it's really important when you're looking at dislocations from this axillary view to understand what's the acromion and what's the coracoid, because that's what's going to tell you posterior or anterior dislocated if you get this image instead of an axillary wide view or lateral wide view, okay? We will stop there for now. We'll see plenty of dislocation pictures and help you kind of figure it out. Questions for today? All right, I will hang up here for a few more minutes.